Now I would like to invite Dr. Hanife Özbek to officially open our conference first.
Kıymetli misafirler, vaktinizi almayacağım. Çok kısa bir konuşma yapacağım. Bu konferansı Sayın Bakanım adına resmen açıyorum. Hayırlı olsun.
Thank you very much. Teşekkür ederiz. Okay. This is the end of the first session of this afternoon, but we are not going to give any breaks, I'm sorry. We will continue with the keynote speakers. So I thank to all our participants for welcome addresses and invite the keynote speakers to the stage, please.
Okay, whilst we're waiting for the keynote speakers to come up stage, I have one announcement. We will have a reception this evening between 6:30 and 8 p.m. The location is a place quite close to the reception desk of the hotel. I think you will have no problem finding the place. So please, we expect to meet you there at 6:30 this evening. I have my actually there are three of them because my co-moderator is also presenting. So we will start off immediately. We're going to do this within an hour, and please note that there shall be no questions after each presentation. So I'd like to first ask Suwit to make his presentation on from ICIUM 2004 to ICIUM 2011, Challenges and Opportunities for Medicines Access and Use. Suwit? Your preference.
Thank you, Chair. Dear friends and colleagues, in this room and in Alexandria. I hope you can see me. First of all, I would like to sincerely salute the courage of the organizer, like John, Dennis, Anita, and others, who dare to invite me to speak here. Everyone in the global health field knows that I'm a troublemaker. And they know that I'm going to create big trouble here. I hope that that's the reason why they want me here. I use my slides that I presented to you, many of you, since 2004. I spoke at the closing session, but I just put those on the yellow one. Is this the one that we use for it? Okay. I will try to share with you what I see as the change among all four stakeholders in relation to improving use of medicine in the past 7 years. You don't have to agree with me, but you have to listen to me because I'm the speaker. What's the change among developed countries' government? You see their strong commitments on global health. You see huge amount of money coming into global health from mere 5 billion US dollar per year now to more than 20 billion. But this is teeny, very small, as compared to their GDP or their 0.70% of their GDP on the development. This is very small. In spite of this very small, they want to control. They want to control. They want to control the intergovernmental organization like WHO. In WHO, one country, one vote. So no matter how big, how rich you are, you have one vote. No matter how small you are, like Vanuatu with less than 10,000 people, you have one vote, equal to China with 14 billion people. Which country don't like that? They don't have much influence. But they can influence IGOs by using money. Using money. They invest a lot in IGOs and use their money to direct IGOs. I'll tell you more story. When they are not happy with IGOs, they create so-called global health partnerships, like Global Fund, Gavi, and many others, more than 100 of them. In this global health partnership, they have more voice. In the board of the Global Fund, for example, there are 20, 21, or 22 board members. Rich countries share about 8 or 9 seats. It's better than 1 in 192, right? So they influence global health partnership, they influence IGOs. They also, on the other side of development, in the trade issue, they push for stronger IP, particularly TRIPS+. Many of us in developing countries will have to face with this proposal of TRIPS+ in the trade negotiation. And in all international discussion, health discussion, they try to limit the scope of TRIPS flexibility. 2 months ago at the UNGA, there's a political document coming out. There was before that document came out, there was a big fight. Developing countries want to put TRIPS flexibility and Doha into the text. Developed countries want to kill both. Developed countries argue that the TRIPS flexibility is only used in urgency and emergency and extreme urgency. They didn't read the text of the TRIPS agreement, which also include public non-commercial use. So they try to forget Doha. They also support aggressive marketing of the drugs by the industry because the industry pay for their political campaign. They have little commitment to improving use of medicine. In the opening session, some people very politely say that half of the medicine are used improperly. I think they are very polite. We all know damn well that more than 80% are used improperly, not 50%. This is the developed country. Now, how about my country, a developing one? Someone said that DC means developing countries. My country maybe DC means difficult countries. We have a worst flood in the last 70 years. We also commit more to health. The African Summit has an Abuja declaration to commit 15% of the national budget on health. I'm not sure whether they have done that or not. We also committed to MDGs. Many countries committed to achieving universal health coverage, which can be very beneficial to improving use of medicine or detrimental. One example is my country. Previously, no one cared about the National Essential Drug List because it doesn't mean much. But after universal health coverage, essential drug list become a right. Once the drug is in the list, it becomes the right for everyone. So national essential drug list become having more teeth and claw. And embedded in the national essential drug list are rational use of drug. At the same time, it can be detrimental to improving use of medicine. One of our 3 main health insurance, the Civil Servants Benefit Scheme, which I belong to, continue to pay more than $60 million per year for a useless drug called glucosamine for the osteoarthritis. $60 million per year. So it can be both positive and negative. Please come and listen more to Jonathan Quick on his session. Developing countries receive huge amount of money from Gavi and Global Fund. The question is, what happens if tomorrow these two funds disappear? How many countries can sustain their access to antiretroviral drugs? Huge amount of money. They try to protect TRIPS, flexibility, and Doha. Some of them even went more courageous to really implement TRIPS flexibility, compulsory licensing against antiretroviral drugs, and in my country also against anti-cancer drugs. This is a jack, challenge the giant. Not only one giant, many giants at the same time. These are countries like Brazil, India, Malaysia, and even Indonesia. They also have little interest in improving use of medicine, only when they have universal health coverage, where the big money, where they have to shoulder the responsibility of paying for drugs, that they will have to start to realize the importance of improving use of medicine. How about the IGOs? I want to talk only on WHO, my beloved organization. It is my organization. All the staff in the WHO are my staff. Because I pay tax to my government, and my government pay contribution to the WHO to pay the salary of Margaret Chan down to the janitor. When I said this to Dr. Lee, the late Dr. Lee, many years ago, he immediately picked out his pocket, his wallet, and gave me 100 Swiss francs. Bring back your money. But it's true. The WHO is our organization. It has three very strong characteristics. First, a very high social credit. As a rural doctor myself, when I was practicing in a rural hospital, whatever WHO recommend, I never question. It's like God will. This is the WHO recommendation, okay, I go ahead and do it. Because they have very strong social credit. Second, the WHO have access to the best expertise in the world. Nobel laureate or whoever. When the DG call him and says, please, we need your expertise, come and help us, be our expert committee. I don't think that anyone will decline. As compared to Dr. Suwit, write a letter to Nobel laureate. They may not even open the email, right? So the unlimited access to world-class experts is very important for the WHO. The third one is that it is the only UN organization that has the widest representation in the country. Network of 145 World Health Representation Office, and maybe several hundred or thousands collaborating centers. So they are like peripheral nerves that spread all over the world that can bring into the WHO information and situation. These are their strengths. But nowadays they are in bad shape, real bad shape. As I said, this is the organization I love. They are in the process of big reform. I want to read to you the intervention by the Thai delegation, representing by the Deputy Permanent Secretary, then the Deputy Permanent Secretary, not me, at the World Health Assembly last May, in the session on WHO reform. And I read, not all of them, just part of them. WHO has been facing 4 serious problems. First, it inherited all the UN bureaucratic systems established since Second World War, whereby so many rules and regulations were formed to such an extent that it is the lawyers who really rule the organization. Its long bureaucratic system also falls into the situation of Peter's principle, whereby majority of its staff are eventually promoted to the position of their incompetence. Second, the regional structure and country offices, as well as the collaborating centers, are outdated and inefficient, but consume more than 2/3 of the organization budget. You look at all the 6 regional offices. I think at least 1 or 2 deserve to survive. I don't tell you which one. You guess it yourself. The third problem is the state-only nature of WHO. Other partners like inward academia, civil societies, and private sectors are considered just as observers, while they are having more and more influence in the global health. Fourth is the financial situation. It has been expanded so much in the last decade without real increase in its regular budget. Now, 80% of the WHO budget come from donors. 80% come from donors. The largest one constitutes more than 30% of this donation. And it earmarked 99.98% of its donation. What does it mean? It means that WHO is thus de facto a donor-driven organization. Nearly 200 member states pay their contributions to maintain the office and salary of all WHO staffs, from the janitor to the DG, just to work mainly according to the donors' mandates. WHO is not the organization that majority of the member states co-own anymore. We need a new global health organization. We need an organization which is inclusive, whereby states, civil society organizations, and the private sector work side by side. An organization where partners can work together based on trust and collegial relationship. We need an organization where members come to give and know and to commit their public spirit, not to take from other partners to fulfill their greed. The main question is whether we can reform the WHO into what we want. We do not believe that the WHO can be reformed. We believe only in its reborn, which is very easy to do. Member states just stop paying contribution and do not come to the World Health Assembly and Executive Board meeting, and then the reborn of new global health organization can be seriously started. End of the quote. That's not what I said, that's what he said. I just read it. Anita mentioned about rational use of drug resolution at WHO. I was there at the drafting session. I see very clearly that the ADG who was there was very biased. We are discussing the text of the resolution proposed by the Secretariat. What he did was try to send signal to the able director who was working on the text. Not to, you don't say anything, I say only. And what he said is that whatever the influential partner proposed to delete, he said, yes, we delete. We delete our own text. And finally, we have to invite him out of the room because he's useless. And this is rational use of drug resolution. And after we have that resolution, what happened? Nothing. You fight for a resolution at the WHO, but nothing happened. Many other stories to tell, but you have to come to talk to me later. I have been 12 years actively involved with the WHO, so it's from my own experience. Now come to the NGO community. They are very strong. This is our hope, much stronger. Engaged in everything. In the Global Fund Board, we have 5 strong NGOs, including 1 private sector and one private foundation. They are the strongest board member. With all the evidence, very clever, and continuity of wisdom. The challenge is that they now become the recipient. They now become the implementer. They lose the power of being a watchdog. They're also not interested in improving use of medicine. Industry don't talk about that. They're never interested in improving use of medicine anyway. They are now very powerful because of merger and acquisition. They influence everywhere, in WHO, in the Global Health Partnership. Their strength is their efficiency, what they said. It's a pity that even INRUT now has to accept support from industry. Next, ICIUM, if you don't have money, come to me. I'll mobilize fund for the next ICIUM without having to receive any money from the industry, with the condition, with one condition that we invite them on the organizing committee. We don't want them to influence people under the table. Come sit on the table and don't bring your money. We don't want your money. We can organize it with our own money. And please come on the organizing committee. What we do now is on the contrary. We receive your money into a central pot, but you don't come to organizing committee. And they influence people around the table without knowing. We should be more transparent. Actually, we are now in the Third World War for 2 decades already. The war against ourselves, our greed. So what we should do for INRUT? I'll finish in 1 minute. What do we want for INRUT? Do we want to be a talk-only organization like WHO? Or do we want to be a do-only organization and knowing nothing like UNICEF? Or do we want to do everything and know everything like the World Bank, but to be wrong all the time? Or do we want to know nothing and do nothing like UNDP? This is not what I said. The first 3 was from Professor Adeto Kunbo Lucas. The last UNDP was from Dr. Lee. I quote them. I think we should be a knowledgeable organization, network, that aim to change the world. We should aim at changing the world. Sorry, I missed the last slide, which I showed you last time when I was in Thailand. I want to see INRUT as a network that can link the power of wisdom, the social power and political power to change the way we use medicine. And please meet more often. If you want to be successful, 7 years, I already forgot that you still have an ICIUM. I commit to host the next 5 years. If you 7 years, I won't commit to that. If 5 years, come back to me, and I'll get money for you to organize that without the money from the industry. Thank you.
It would be very dangerous for me to say anything like that. Our next presenter is Ricardo. Ricardo is from the Ministry of Health of Mexico, and he's going to talk on the public policies to improve drug access for chronic diseases, the experience of Mexico.
Hello, good afternoon. I think I'm one of the few people that have been in 3 ICIUM meetings in 1994, 1997, and now 2011. So thanks to Anita and Dennis for inviting me. And I also heard Suwit in the last time. It's always a hard critic, in my opinion. Well, my presentation will address the experience that we have in Mexico to improve drug access for chronic diseases. So I will present in very briefly which are the main characteristics of the country, some aspects of chronic diseases, which is the pharmaceutical market, how can we improve drug access and using the drug access framework, and then put an example on HIV/AIDS, and finally, which are our national policies and which are the results that we're getting out of it. So the country, it's about 112 million people, and the life expectancy is 77 years. But the final report of the UNDP is that the life expectancy, the actual life expectancy, after adjusting for health status is 67 years. So that represents that we spend 10 years of our life sick. And most of it is related to chronic diseases and now accidents and unsafe environment. Then the increasing prevalence of chronic conditions, we'll see in the next slide that there are 4 of them or 5 of them that are very important. One is overweight and obesity. The second, hypertension, diabetes, type 2 diabetes, HIV/AIDS, and cancer, mostly breast cancer and cervical cancer. And these diseases account for 78% of the total deaths in the country. And the healthcare sector that we have is complex. The financing is public, most of it, but we have 2 large fragments. One is the Social Security services, the population that is covered with medical benefits, social benefits, and economic benefits, pensions. And those who are not with the Social Security, those that are covered by the Ministry of Health. For them, obviously, there are different schemes and packages of services. I will describe briefly that. And most of Social Security services are provided to those that have formal employment. The coverage of these 2 institutions is about 95%, which is increasing every year. But at the same time, it's a very inequitable system because most of the people that are with the Ministry of Health have high out-of-pocket expenditures. This is a change. The slide is trying to show the change in the double burden of disease that in the right side. I always have trouble with the left and the right. This is the infectious diseases in 1980. We track this and we present this slide all the time because we try to show how in a very few period of time, the scenario of the chronic and infectious diseases is changing in Mexico. So in the past, diarrhea and pneumonia were the main causes of death in 1980. And now, in 2009, it's heart disease, it's diabetes, and cancer. So we are facing an important problem in terms of the double burden, as we call it. Then what's the main point here? One is the cost. How much does it cost to have these conditions? So this analysis, the figure only depicts what's the financial impact of overweight and obesity. As you can see, the upward slope is the total cost of this condition. This represents 2 different slopes. One is the direct cost that is because of the diseases such as diabetes, hypertension, cerebrovascular disease, or cardiovascular disease, and cancer. And the other one is the indirect cost. This indirect cost represents the loss of productivity. So that concerns the Ministry of Health in terms of which can be the best strategies to address the problem. Then, when we are compared to other countries, and one of our reference comparisons is the OECD, then I didn't hear anything about OECD for Suwit, so maybe I can say that. This is the 28% is the total spending on drugs as a percentage of total health expenditure. So the only country that spends more than us is Hungary. And the next is how much money is the people spending on drugs, even if they belong to healthcare systems, even Social Security or the Ministry of Health. So in plain terms, what I'm trying to show is that for every 10 Mexican pesos spent of drugs, 79 pesos are paid out of pocket. This represents and again, in an inequitable system. Now, what's the size of a pharmaceutical market in Mexico? In 2009, the pharmaceutical market accounted for about 11.9 billion US dollars. This represents 1.2% of the GDP, and it's among the top 15 global markets. And it's the second in Latin America after Brazil that has been growing very rapidly in the past few years. But what it's important to show is what's the size of the volume for the public sector and the private sector. As you can see, the volume in the public sector is 35%, but the private sector has 65%. And the value of that for the public sector is 20%, and for the private one is 80%. So that represents what are the weaknesses in terms of facing the important problem of the market in Mexico. So going back to the essential elements to analyze the national drug policies, and we're taking three different aspects. One is access, that represents availability and affordability of drugs, and the national drug policy shows that there are two different aspects in that way. One is to assure effective access to medicines, availability and access to medicines, and second, to protect people against health risks, safety, efficacy, and quality of medicines. And then the next is quality. Quality is also related to promote rational use of medicines, prescriptions, and dispensing and use. And the final is the use. This is appropriate and effective use. It's by health professionals and by the public. And that has to do with promotion of innovation in drugs and for the Mexican population, and also to raise the competitiveness and the pharmaceutical industry. One of the problems that we face, and I will refer only to the population that is not covered by the Social Security because they have full benefits, is those who have no right or no access to Social Security. For them, the government started the program that is called System for Social Protection of Health, that we call it's a social health insurance that offers subsidized, publicly provided health care to people without Social Security, as was mentioned before. So the popular insurance that we call in Mexico, it has four key objectives. One is to increase public spending in health. The second is to stimulate efficient allocation of resources. The third is to protect families from excessive health expenditures. And the fourth is to transform the incentives in the system from the supply side to the demand side. In July 2011, we have already 49 million people affiliated with the Seguro Popular or popular insurance as we know it. So what's the importance of this, or why I'm explaining this? It's a very simple thing. One is the system, which is the System for Social Protection of Health. And this system has three funds. One is the medical insurance for the new generation that has funds for children under 5 years old. The second, the one that is in the red arrows, is the protection fund for catastrophic expenditures. And the third is the catalog of universal health services. Which are the packages? As I was mentioning before, there are different packages that makes difficult to understand. One is this fund is only for pediatric care, and it provides care to 128 pediatric medical conditions. Then the next is public health interventions, mostly vaccines. And then the protection fund, the FPGC, as everybody knows them in Mexico, covers high-cost, low-prevalence illnesses such as HIV, AIDS, and cancer. And the final one is the most prevalent ambulatory and hospital care illnesses. Who provides this? The fund, the System for Social Protection, doesn't provide services. It only buys the services for the Ministry of Health. So it allocates the money to the state ministries of health facilities. And the beneficiaries are the people without Social Security. So which is the distribution for the fund, the one that was in the red arrow? As you can see, most of the fund, 38%, goes to care for people with HIV/AIDS. So that represents 35%. 25% goes to care for people with cancer. And 15% goes to care for people with, for children for neonatal intensive care units. So this is the main, and you can see in 2010, these three, HIV/AIDS and cancer, different cancers, breast cancer, cervical cancer, and cancer in children, mostly leukemia, accounted for 77% of the FPGC expenditures. And I'll take only one example, which is HIV/AIDS. HIV/AIDS, this is the prevalence that we have in Mexico, it's 0.38%, and it's increasing. We are below the target of the Millennium Development Goals, so we are not reaching this estimated prevalence expected. But still, despite that this prevalence is increasing, the government has taken care about these patients since 1984 with different funds. This line shows which is the progress. I don't expect to read the entire slide, but what I'm trying to show is that the government has implemented in different years different programs to fund for these patients, for care for these patients. And we are right now analyzing these three aspects: the funding, how much money are we spending on them, the affordability, if it's possible to continue funding these patients, the different antiretrovirals, and then how these are using the antiretrovirals. What is important to mention, maybe I can reinforce some of the comments of my predecessor, is that most of the success of the government is because NGOs are pushing really hard. The society pushes for getting appropriate drugs for patients with HIV/AIDS. That's something that the government feels the pressure to do. And now, what's the problem that we're facing with that? First is that the number of patients with diagnosis and with treatment is increasing, but at the same time, there is the response of the government is different. So here we see an effect that we can call adverse selection, because most of patients are with the Ministry of Health, and very few patients are with the Social Security. And the reason is that the Social Security is sluggish in terms of getting the new drugs as does the Ministry of Health. So that happens that patients migrate to one system to the other. So that's another problem that we're facing, because there are two systems that makes the situation inefficient. So one of the policies that the government is trying to push is to create a single fund for this kind of patients, in a way that either on one institution or the other, patients will be able to get the medications they need. Next is the health improvements. That's another problem. Besides that, it's increasing the number of patients and the inefficiency, that there is a situation in which the efficacy of the drugs causes that there are the survival right now is 15 years of survival with these patients with the treatments. In 2008, it was 7%. In 2009, it decreased by 28% to 5%, and in 2010 is 3.2%, sorry, which is 54%. So that represents more patients, more time, and we need to find efficient ways to organize the funds to provide care to these patients. Now, coming back to the strategies, these three strategies, access, quality, and use, have been implemented in the Mexican government. I'm not supposed to read all these strategies, but I can show you the results of these strategies. One is access. So we are trying to, sorry. Sorry. That's a very complex technology. The strategies regarding access, there is the estimated savings that we're getting, about 11 billion pesos in the negotiation of the prices in patent drugs with the industry. The second is the use and prescribing drugs of generics. And the third is the package that the registries for diseases of chronic diseases, for medications for chronic diseases, such as hypoglycemic, cholesterol, and cancer drugs are being released. This reduced the price to 70%, And also the estimated savings for these measures is about 2.5 Mexican billion pesos in the health sectors in the next 4 years. Regarding quality, for 2008, there are 2 types of drugs, generic and reference, and physicians can only prescribe medications of the essential list of drugs and by a generic name. Now I have to be careful. Then the use. Use is also very important. Use in 2008, the Ministry of Health stopped or prohibited the entry of pharmaceutical representatives to the health facilities. In the past, it was very often that they went to the primary care clinics or to the hospitals to promote the drugs, the new drugs. Update medical personnel to treat chronic patients. There are a number of different strategies. The third is the development and use of evidence-based clinical guidelines. There is a specific institution within the Ministry of Health that is doing the clinical guidelines that are valid for the Mexican contexts. The next is the pharmacist, that is included in the prescription process. There is an exercise in which there are 23 hospitals implementing this because we lacked the presence of the pharmacy in the pharmacists of the public facilities. And finally, the advertising provision of miracle products. That's another problem that we're facing in Mexico that impact negatively the appropriate care for chronic conditions. What's the final agenda or the unfinished agenda that we have? We have several problems. One is funding. We need to consolidate the financing. The example that I gave in the HIV patients is the same for cancer. So we need to consolidate the financing. The second is create a pharmacoepidemiology network. It's just beginning the effort of the Mexican government to implement pharmacovigilance and pharmacoepidemiology networks in the country. There are about 6 or 7 states doing it right now. Then is participation, promoting social participation for other conditions. The HIV/AIDS example is very good in terms of the political power they get to, even there is a National Council of HIV/AIDS and it's promoted by NGOs. And finally, doing research in different fields, use and prevention, and use of drugs, rational use of drugs, in which we have been working a lot for several years is one example. So with this agenda, which is unfinished, I think that we can, in some sense, contribute to the learning process. And I like to finish my presentation saying that every time that I come to ICIUM, it's a learning lesson for me. Thank you very much.
Thank you very much. Our last presentation for this session will be by my co-chair, Mehtap from Turkey, and her topic is Healthcare Reforms and Pharmaceuticals, Lessons from Turkey.
Thank you very much. I actually would like to thank the organizing committee for giving me this opportunity to talk to such an distinguished participants from all over the world. I was asked to talk about the healthcare reforms in Turkey and its impact on pharmaceutical policies. I think I need the rest of the conference to discuss what we have done so far since 2003, but I know my limits, so this is a great challenge for me to summarize everything we have done in 20 minutes. Our health transformation program started in 2003. You can see the pillars of the transformation program here. It's not very much different from what other countries have done so far, but we have done a lot of work to make the transformation program become reality. Oops, sorry. I think I'm not good. Okay. In this actually figure, you can see some selected, very much selected healthcare reform initiatives. These are the major reform initiatives since 2003. 2005 is a very important year for the Turkish healthcare system because we had major changes in that year. Actually, we used to have a social security organization which covered almost 50% of the population, and that organization actually both financed and provided healthcare services to its beneficiaries. What we have done, actually, we transferred the healthcare facilities of that organization to the Ministry of Health. So the Ministry of Health became the main provider of healthcare services. So in terms of achieving purchasing and provider split, Social Security Institution, which was established in 2006 and covered all existing financing schemes, which were 5 actually at that time, had the responsibility in financing side, and the Ministry of Health had the responsibility in provision side. So this actually changed the whole scenery in terms of access, especially. I'm going to talk about that in a minute. The other actually important change we had was extension of green card holders' benefits. The green card is a scheme for the poor people in Turkey. So the government announces a level of poverty, and people who are under that level, under that poverty level, their healthcare expenditures are covered by the public, from the public purse. But until 2005, only the inpatient care services were covered by this scheme. So if you were a green card holder, meaning if you were poor, only your expenditures in the inpatient care sector were covered by the government. In 2005, this actually coverage was extended to outpatient care and also medicines, which meant actually at that time around 10 million people were under this green card scheme. Another important change in terms of healthcare system, healthcare reforms, was the coverage of population below 18. Without looking at their parents' insurance status, these people were, that group of population was covered in terms of healthcare expenditures. At the primary level of care, a family practitioner scheme was introduced, and it started as a pilot scheme in 2004, but then it was extended to the whole country in 2010. But I must actually state here that we do not have a compulsory referral system. So this means that these family practitioners actually do not act as gatekeepers, as we understand. So the people are people that decides whether to go to the family practitioner first or to the secondary or tertiary care directly. When we are talking about discussing the impact of a program, we can look at from different dimensions. Of course, there are lots of dimensions that we can discuss here, but I took only 4 main dimensions of when analyzing the impact of the program. I'll look at the improved access, I'll look at the increased share of private providers, satisfaction with the system, and increased health expenditures, and then come back to the pharmaceutical policies and what we had in that area during 2003 and until now. Now, if we look at improved, in terms of improved access, the only data we have for analyzing the data before the access problems before 2003 comes from the National Health Accounts Household Survey, which covered 10,000 households, and this survey was representative of the whole country. And in this survey, actually, we asked people what they did when they felt in need of healthcare. And in that survey, 13% said they did nothing, 19% said they referred to self-treatment, and 30% used self-prescribed medicines. So this means that more than 60% of the people who were in need of health care before 2003 didn't refer to formal health care, but tried to cure himself or herself with self-treatment materials. When we look at this graph here, this actually quite clearly shows the improvement in terms of access. When we look at, this is outpatient visit per person per year. In 2002, this was the figure was around 2.8%. But now in 2009, it's 7.20-something%. I cannot say it here. Actually, I think that because of the computer version, it's now 7.3%, and it is increasing. So this shows how access have improved with the effect of these reforms. But here we cannot see whether this was because of the meeting the unmet need before 2003, or whether there is an influence of the performance-based payment system that we started to use after that period. So we need to we need to do an impact analysis in that sense. We can see the increased share of private providers. This is the number of outpatient visits to private hospitals. You can see that in 2002, it was around 4 million, but in 2009, it reached to around 47 million. So the share of private providers increased quite a lot, so which actually also had an impact on the increased healthcare expenditures. When we look at the satisfaction, actually, in the opening session welcome address, our Director of General Health Insurance also mentioned about increased satisfaction. We can see that the satisfaction with the system increased quite dramatically from 39.5% in 2003 to 73% in 2001, and he told that it was 80%, and in terms of pharmaceutical, in terms of satisfaction from pharmaceutical side, that point has reached to 90%, as he said in the morning in his welcome address. Of course, what we had, I mean, if you are putting a lot of effort in improving access to the healthcare services, and if you are putting a lot of effort to cover as much as possible, this means that you have to face the burden of increasing health expenditures. It's inevitable. You cannot say that I'm not going to give the best health services available to a large amount of population, but I'm going to spend less than I have spent earlier, or less than some standards, whatever they are. So you are actually taking into account that your expenditures are going to increase, and this can be seen from this graph. This is the health expenditures place in GDP. It used to be in 2009 it was 4.9%, and in 2009 it's 6.5%, and it's increasing inevitably, as I said earlier. Now, if you look at the pharmaceutical side, in terms of the pharmaceutical reforms actually went, of course, in parallel with the healthcare reforms, and many policies that were adapted for the pharmaceutical side was actually a reaction to the increased health expenditures. Because in Turkey, there's a belief that we are spending a lot of money in pharmauticals. This is correct in some sense, but wrong in some sense as well, as I said earlier, because if you are talking about improving access, if instead of twice a year, a person is visiting a health facility 7 times a year, this means that, and it is always attached with a prescription, this means that your pharmaceutical expenditures will increase. And also there's actually a conflict in terms of terminology, but I'm not going to talk about that, because my colleagues after this session are going to talk about the real impact of healthcare reforms on pharmaceuticals, and I'm sure they are going to share more up-to-date data with you. But what we changed the pricing and reimbursement rules after 2003. In 2004, external reference pricing was introduced, so now the ex-factory price of a pharmaceutical in Turkey, an original in Turkey, is the cheapest of 5 countries in Europe. These are Italy, Greece, Portugal, Spain, and France. So this is the cheapest of these countries. So, and then the VAT was decreased from 18% to 8%. And then a positive list was introduced in 2005. At the beginning, when the green card coverage was extended to the whole green card holders, there was no co-payment. But then the pharmaceutical expenditures of the green card holders boomed, so they had to make extra measures, and a 20% co-payment was introduced for the green card holders. And then in 2005, internal reference pricing started, actually, which meant that we had drug equivalent groups, so the reimbursement agency actually reimburses the cheapest, the price of the cheapest plus 30%, and if there's a difference between that price and the real price of the drug, it goes from out-of-pocket sources. This limit actually has changed quite a lot over time, and a lot of changes have been made in that sense, and I'm going to talk about what the limit is now because it has changed very recently. In 2010, a global budget was introduced, and so the government stated that there's going to be a ceiling that the government will pay for each year, starting from 2010 for 3 years. So we are now coming to an end in 2012. We don't know how this is going to continue. Is it going to continue or under what conditions? But when making this agreement with the industry, actually one point lagged, which was what is going to be done if the budget exceeded. So yes, for 2010 and for 2011, the budget was exceeded, and so the government took extra measures, and these became as additional discounts for public source prices of the drugs. So our pharmaceutical expenditures has also increased in line with the increases in healthcare expenditures. But looking to this slide, in this way is not correct, because we have to match actually all the changes I have told earlier with the years here. In my slides it was like that, but as I said earlier, I'm sorry for that, because of the I think the version of the program used, I cannot see them here. But if you actually match the what we have achieved in terms of healthcare reform. For instance, if you look at 2005, as I said earlier, this is quite an important year for Turkey, because the coverage was extended quite a lot in terms of green card holders and social security institution, and the pharmaceutical expenditures increased quite dramatically in that sense. Now, after these reforms and their impact on especially healthcare expenditures, we started to talk about health technology assessment. And currently, we are actually doing some kind of health technology assessment, because pharmaceutical companies, when applying for reimbursement status, have to prepare pharmacoeconomic analysis in their dossier, application dossier as well. So it is taken into account. The pharmacoeconomic results are also taken into account. So the issue of further discounts came into place. Rational drug use, that's why we are here actually, as all of we are talking about rational drug use, and we have a session after this session just going to talk about the rational drug use in Turkey, and some other measures like restrictions on prescriptions were also taken into account. After my presentation, after I got this one ready, actually, two major changes were made. First, on 2nd of October, the Ministry of Health was reorganized, and which meant that now we have a Turkish Agency for Medicines and Medical Devices, which is going to be attached and semi-autonomous authority to the Ministry of Health. At the moment, we have General Directorate of Pharmaceuticals and Pharmacies, but this time, in a year's time, we are going to have a semi-autonomous body, so the pharmaceutical and medical device policies are going to be undertaken by that newly built body. And also on 5th of November, the reimbursement rules for pharmaceuticals have changed quite dramatically. The public discounts, which was 32.5% for original drugs, was increased to 41%. And the internal reference pricing upper level was dropped to cheapest plus 10%. So this had a great impact on I mean, we're expecting this one to have a great impact on the Turkish pharmaceutical sector, both in terms of the providers and also the users. We don't know what effect this will have on the pharmaceutical companies and also the patients, of course. I mean, we don't know if patients are going to be asked to more spend on out-of-pocket expenditures, or maybe some drugs will not be introduced or launched in Turkey just because of this very high level of discount rates. But I think we have to, and 2012 is quite near now. This is the end of the global budget agreement between the government and the industry. So we should actually start talking about and thinking about what we can do, because there's a limit to discounts. You cannot go further with further discounts, and there's a point that this will harm both the industry, both the providers, but also mostly the patients. So we should actually evaluate that area very importantly. And my last my last message for the Turkish healthcare system will be that we have to work more on to analyze the impact of each reform on different aspects of the healthcare system if we want to make evidence-based health policies, and we should rely on more evidence than wishful thinking or just our hunch. Thank you very much for listening.
Good. We've come to the end of this session, and you will agree with me that it's been quite exciting. And I'd like to thank all the speakers and also you, the audience, for your patience and interest in all the presentations. We will take a 10-minute break and report back at 4:30 for a session on rational medicines use issues in Turkey, yesterday, today, and tomorrow. So, ladies and gentlemen, you have a 10-minute break. Thank you all.